Evening, everyone, depending on where you are. And you're welcome to the very first NSA webinar series. This is the 6th series, first session. And today we have 2 topics to be presented. We have a moderator in the person of Dr. Rukaya CD. She is a senior registrar in the Department of Anesthesiology and Intensive Care, Aminu Kano Teaching Hospital, Kano. But she's waiting to be certified as a consultant because she has passed her part 2. So we believe she's competent to handle this webinar effectively. So I will hand over to, well, before that, you said that this is basic sciences that we are taking, to take us through the journey throughout 2023. So I will hand over to Dr. Rukaya CD now to take over the webinar to start. Thank you very much. Dr. Rukaya.
Good evening, everybody. Welcome again to today's webinar. This is the 6th webinar series and then the first session. It's actually our first NSE webinar for the year. We'll be having 2. The first will be the overview of the respiratory physiology by Dr. Maimie, and then the second will be the overview of the cardiovascular physiology by Dr. Odibo Michael. We'll be having the 2 presentations back to back, each presentation period of 30 minutes, and then the question and answers will follow afterwards, which will last for a period of 20 minutes. So the in-house rules will be to please kindly mute your audio with the presentations, and then in case of any questions, please kindly raise your hands. And then we'll also have the chat box where you can write your questions. So welcome again. I'll now hand over to the first presenter, Dr. Maimie, for the overview of the respiratory physiology. Dr. Jig.
Francis, will you want to share your screen and start? No, not this one.
Good evening, professors. Good evening, consultants.
Not this one. This is not the first.
All right, then. So please, can you share from the side? We know I couldn't share initially, so kindly share from the side. This is one I will share.
Good day, my seniors, colleagues, and everyone in here. My name is Kpehe from the Aminu Kano Teaching Hospital, Anesthesia Department. Today I've been tasked to provide an overview of the respiratory physiology. Now, each day at induction, we anesthetists take over the respiratory functions of many of our patients. We maintain gas exchange as well as use the respiratory tract for the uptake and elimination of inhalational agents. And after a safe and successful surgery, we hand over this vital function to the legitimate owner. Now, the anesthesia we provide tend to alter the normal respiratory physiology. This is the reason why every safe anesthesia will require a good understanding of the respiratory system and its physiology. The function of the respiratory system is essentially gas exchange, that is oxygen delivery and carbon dioxide removal. Other functions include to filter, warm, and humidify inspired air, which is primarily done by the upper airways, acid balance, and pulmonary metabolism. There is the respiratory tract. As you can see, it starts from the nasal cavity, moving to the oropharynx, the trachea, the bronchi, the bronchus, also the terminal respiratory bronchioles, the alveolar sac, and the alveoli themselves. There's also the diaphragm, which is the principal muscle of respiration. It accounts for about 75% of respiratory work, inspiratory work, doing quiet breathing. The respiratory tract is also divided into upper and lower respiratory tracts. Now, the larynx is a very important landmark. It separates the upper respiratory tract from the lower respiratory tract. The upper respiratory tract consists of the nasal, oral, and laryngopharynx, while the lower respiratory tract, that is beneath the larynx, starts from the trachea and ends at the level of the alveolar. Webel classified the lower airways into 23 generations. Generation 0 to 16, which span from the trachea to the terminal bronchial, constitute the conducting zone, while generation 17 to 23, which commences from the respiratory bronchial to the alveolar sac, constitute the transitional or respiratory zone. And the respiratory bronchial, from the respiratory bronchial to the alveolar sac, is where gas exchange occurs. Here is the alveolar sac. In adults, there's about 300 million honeycomb, cluster honeycomb units. Now we zero in on the alveolus. Multiple are referred to as alveolar. So within this alveolar, you have thin layer of fluid that contributes to the surface tension. Over this thin layer of fluid are surfactants that repel each other, ensuring that this alveolar is patent. The alveolar contains basically three cell types. You have pneumocyte type 1, which is structural in nature. It provides surface area for gas exchange. Pneumocyte type 2, which secretes surfactants that lowers the surface tension. And pneumocyte type 3, which are alveolar macrophages, the function in immune response or defense. Now, there's the surface tension. The surface tension is the force that pull together molecules of water on top the surface of water. As we said previously, the alveolus inner lining is lined with this thin layer of fluid, and the attractive force between the water molecule is greater than that between the air fluid interface, and this results to alveolar collapse or atelectasis. The Laplace laws predicts the pressure contained within the alveolus and is designated as pressure equal 4 times the surface tension divided by the radius. This implies some other alveolus with small radius has greater pressure. So two things happen. They tend to collapse into larger ones, which means they are unstable. And secondly, the greater force within the alveolus tend to draw water within this alveolar by transudation, leading to pulmonary edema. The surfactant is very important because it's overcome the problem of surface tension. It lowers the surface. It's produced by type 2 pneumocyte, which is a mixture of phospholipids. It contains a hydrophilic and hydrophobic ends. It lines itself over the water the thin water lining in the alveolus and repaired each other, and by so doing ensured that the alveolar is patent and does not collapse. The alveolus is patent and does not collapse on itself. Now, with the presence of surfactant, you have reduced surface tension, you have increased lung compliance, it prevents atelectasis, pulmonary edema, ERES, and ensure that the alveolar or alveolar is stable, that is, smaller alveolar cannot empty into larger one. The respiration mechanics. Respiration is essential for the maintenance of pH, oxygen tension, and carbon tension homeostasis. It involves two cyclic phases: inspiration, which is active; expiration, which is passive. Inspiration means the drawing of air into the lungs, and this follow a pressure gradient. This pressure gradient is achieved by creating a subatmospheric intrapleural pressure of -5 centimeters of water. The diaphragm is principal organ of inspiration. It accounts for 75% of respiratory rate during quiet breathing, aided also by the external intercostal muscles. However, when there is respiratory distress, accessory muscles of inspiration are recruited, such as the scalenus muscles, the pectoralis major. Now, the diaphragm is also important because there are situations or conditions where the diaphragm is splintered and the respiratory work is impaired. Such condition includes, for example, pregnant women due to the pushing effect of the growing uterus, spleen the diaphragm, patients with increased intra-abdominal pressure like large tumor, massive ascites, or intestinal obstructions, and neonate. They spleen the diaphragm and reduce the FRC, thereby increase the respiratory work. Also, in thoracic and upper abdominal surgeries where range you have inadequate analgesia, the diaphragm is also splintered. Expiration is the pushing out of air from the lungs. It occurs when the intrapleural pressure is greater than the atmospheric pressure, and by default, airflow towards the mouth. Is a passive process but become active when there is increased airway resistance, increased respiratory rate, or exercise. Muscles recruited when expiration become active include the internal intercostal muscles and abdominal muscles. These are factors that will affect respiration. Drugs like sedative, benzodiazepine, muscle relaxant opiates to reduce the respiratory rate. Hypercapnia, hypoxia, pain will increase the respiratory rate, while disease conditions such as asthma will increase the respiratory rate. Now, compliance. Compliance is very important. Compliance denotes how easily the lungs expand. It can be defined as the change in volume for pressure change across the lungs. Now, in poor compliance state, when there's poor compliance, the lungs are stiffer and require more energy efforts to expand the alveolus. The normal expanding pressure of the lungs is -5 to -10 centimeters of water, and the normal chest wall and lung compliance is 200 mils per centimeters of water. The opposite of compliance is elastance. So there are basically two methods by which we measure compliance. You have static compliance, which is obtained when there's no airflow activities within the lungs. The normal value is 50 to 80 mils per centimeters of water. It's reduced when there is conditions such as pulmonary edema, ARDS. Dynamic compliance consists of two components, lung compliance and thoracic wall compliance. It measures both elastic resistance and airway resistance, and it is obtained when there is airflow activity within the lungs. Now, factors affecting compliance can be physiological or pathological. Posture, age, and pregnancy, as well as obesity, are the physiological posture. For example, in posture, erect posture will increase compliance, while supine posture will decrease compliance. On the other hand, disease conditions such as pneumonia, ARDS will reduce compliance, anesthesia itself reduces compliance, while emphysema will increase compliance. The work of breathing can be defined or referred to the work required to move the chest wall or the lungs, or the force that must be overcome so as to expand the lung. There are basically two forces that must be overcome. They include the non-elastic force and elastic force. The non-elastic force is the frictional force, which include airway resistance and tissue resistance, and this actually accounts for the work of breathing, because work is actually done and energy is dissipated as heat. On the other hand, the elastic force is a stored energy that is released as the lungs return to its resting state, usually occurring during expiration, which is passive. However, when the work of expiration exceed this stored potential energy, expiration become active and respiratory muscles are then activated. Control of breathing. The respiratory center is located in the medulla. So the the upper aspect is located within the pons and the medulla. The upper aspect of the pons, you have the pneumostatic area. The lower aspect, you have the hypnistic area, while in the medulla you have the central chemoreceptors, the ventral and dorsal respiratory groups. And now the puncture the expiration. It sends signals inferiorly and influence the dorsal and ventral groups, ventral respiratory groups. The hypnistic center controls prolonged breathing and receives signals from stress receptors. The medulla contains the central chemoreceptors, the dorsal respiratory group, and the ventral respiratory group. The central chemoreceptors located dorsally and laterally sense pH change in the cerebrospinal fluid is stimulated by increased hydrogen ion concentration within the CSF and inhibited by hypocapnia. It sends signals to the dorsal respiratory group. The dorsal respiratory group, on the other hand, is located medially. It receives signals from the stress receptors in the chest wall, proprioceptors at the level of the joints, juxtacapillary receptors, etc., and it sends signals to the muscle of inspiration, the external intercostal, and the diaphragm. The ventral respiratory group is dormant most of the time. Is actually receives signals from the dorsal respiratory group. It has a pacemaker neuron that set the respiratory rate, and it controls inspiratory. It sends inspiratory signals to the diaphragm and external intercostal muscle also. So as you can see, the inspiratory neurons of the ventral and dorsal respiratory group move downward, give force fibers via the ventral gray horn through rootless C3 to C5, which is the friendly nerve, to the diaphragm, as well as intercostal nerve T1 to T12 to the external intercostal muscles, thereby initiating inspiration. So there's the blood vessel, as you can see here. Containing this blood vessel is carbon dioxide. Carbon dioxide easily diffuse across the blood-brain barrier. It reacts with water to produce carbonic acid. Carbonic acid then dissociate to produce bicarbonate and hydrogen ions. Since the buffering apparatus of the CSF is not that adequate due to low protein, the hydrogen ion concentrate, the hydrogen ion will then move on to stimulate the central chemoreceptors, central chemoreceptors. The central chemoreceptors will stimulate the pneumostatic area and also stimulate the dorsal respiratory group. The pneumostatic area also will stimulate the dorsal respiratory group, while the dorsal respiratory group will inhibit the ventral respiratory group that has the pacemaker neurons that set the respiratory rate, and both will send signals to the inspiratory muscles to initiate inspiration. So the respiratory center receive impulse from the higher centers, the CNS, the chemoreceptors, and mechanical receptors on the chest wall. The chemoreceptors, basically there are two types. You have the central and the peripheral chemoreceptors. The central chemoreceptors are situated near the ventral medulla and respond to hydrogen ion concentration in the brain extracellular fluid. The peripheral chemoreceptor, on the other hand, is located in the aorta near the aortic arch and responds to hypoxia and hypercarbia. It doesn't respond to pH changes. It sends signals to the inspiratory center via the aortic nerve, a branch of the vagus nerve, while the carotid chemoreceptors are located in the carotid bolus at the bifurcation of the common carotid artery. It responds to hypoxia, hypercarbia, and pH changes. It is also important to note that the blood flow at this region is very high, 6 liters per 100 grams of T2 per minute. And it sends signals through the nerve of hearing, a branch of the glossopharyngeal nerve, cranial nerve 9. Now, they have other chemoreceptors also that send signals to the respiratory center, and they include the long stretch receptors, which are located in the bronchus. When there is distension within the bronchus, it is detected and it transmits. These receptors detect and transmit signals via the vagus nerve to reduce the respiratory rate and increase the expiratory time. This is referred to as the Herring-Boer reflex. Also, we have irritant receptors that are between the epithelial airway epithelial cells. They detect nausea, gas, and induce bronchoconstriction and hyperventilation. J receptors also are located in the alveolar wall, and they detect circulatory changes and cause shadow breathing apnea. These are also other receptors that are within the respiratory tract that prevent the inhalation of foreign objects and secretions. Lung capacity and volume. So volume, majority of the lung volume are directly measured, except those that incorporate the residual volume. Simple spirometry is utilized to measure lung volume, and the sum of two or more volumes will give you a capacity. These are the lung volume. Tidal volume is the volume of air, the normal air we breathe, which is 500 mils. Inspiratory reserve volume is the additional volume of air over the tidal volume. Expiratory reserve volume is the additional volume of air expired over the tidal volume. Residual volume is the air remaining in the lung after maximum expiration, while closing volume is the volume towards the end of forced expiration. Other hand, lung capacities, as we said, is the sum of two or more lung volumes. So inspiratory capacity is the inspiratory tidal volume plus the inspiratory reserve volume, which is about 300-600 mils. Expiratory capacity is the expiratory tidal volume plus the expiratory reserve volume, which is 1,500 mils. The functional residual capacity is the residual volume plus the expiratory reserve volume, while the closing capacity is the residual volume plus the closing volume. The vital capacity is the tidal volume plus the inspiratory reserve volume, and the expiratory reserve volume, which is 4,500 mils, and is the maximum volume of air expired after maximum expiration. While the total lung capacity is the vital capacity and the residual volume, which is 6,000 mils. And it accounts for the total volume of air in the lung after maximum inspiration. Now, as we said initially, absolute volume are those volumes that incorporate the functional, the residual volume, and they include the residual volume itself, the functional residual capacity, and the total lung volume. They cannot be measured by simple spirometry, so we use gas dilution technique like helium dilution, nitrogen washout, body plethysmography, and radiographic measurements such as X-ray and CT to measure these lung volumes. Now, functional residual capacity is a common term we usually use in our practice. We know it is the pulmonary oxygen store that usually keep giving oxygen to our blood when we're expired, when we breathe whole, and during safe apnea time when pre-oxygenate to tide over the period of apnea as we conduct our laryngoscopy and intubation. Now, it also can be seen as a balance between the lungs to recoil and the chest wall to expand. It prevents atelectasis and minimizes the work of breathing. It can be increased when you're standing, when you apply PEEP in asthmatic patient, and it can decrease when the patient is in supine position, when doing general anesthesia, obesity, and when there's increased intra-abdominal pressure, such as tumors, massive ascites. Now, as we said initially, this is actually a graph. Now we see this is the tidal volume. This is the expiratory tidal volume. This is the inspiratory tidal volume. So the inspiratory, this is the inspiratory reserve volume, which is 2,500 mils. The additional volume of air that is inspired over the inspiratory tidal volume, you have the inspiratory reserve volume, while the additional volume of air that is expired over the expiratory tidal volume is the expiratory reserve volume. The addition of the expiratory reserve volume and the residual volume give you the functional residual capacity, while the addition of the inspiratory reserve volume plus the inspiratory tidal volume give you the inspiratory capacity. The volume of air that stay in the lung after maximum expiration, you have the residual volume. So the addition of the inspiratory reserve volume plus the tidal volume and the expiratory reserve volume get you the vital capacity, and the addition of the vital capacity plus the residual volume give you the total lung volume. So all the volume that incorporate the residual volume to include the functional residual capacity, the total lung volume, and the residual volume itself cannot be measured using simple spirometry. Rather, we use glass dilution techniques, body plethysmography, and other radiographic means to measure them. Pulmonary gas
Dr.
exchange.
Jake, 8 minutes
Now,
more.
pulmonary ventilation is actually the bulk movement of air into and out of the lungs, and pulmonary volume. So their space is the volume of air that does not partake in gas exchange. Volume of air. Now, the combination of the anatomical and alveolar dead space will give you the physiological dead space, and the Bohr's equation is used to derive the physiological dead space. Shunt actually refers to blood that enters the anterior circulation and does not pick up oxygen in the lungs. So they can actually be divided into physiological and pathological shunt. The physiological shunt is usually now pulmonary hypoxic pulmonary vasoconstriction actually minimize the detrimental effect of shunt on oxygenation. It's a protective mechanism that shunt blood away from hypoxic region to better ventilated region, so as to improve ventilation and perfusion matching. It will occur when the alveolar oxygen tension is low, less than 11 millimeter of mercury. Now, the mechanism is actually unclear, but there have been several postulations, one of which is that low pH would cause the pulmonary endothelium to stop producing nitric oxide. This will lead to vasoconstriction. Ventilation perfusion ratio. Ventilation perfusion ratio. So the ventilation refers to the alveolar ventilation, which is usually 4 liters, while the perfusion refers to the blood that is coming into the lungs, otherwise the cardiac output, which is 5 liters. So the ventilation perfusion ratio is the alveolar ventilation 4 divided by the cardiac output 5, which is. Now, here's the wedge zones. Wedge zone is a physiological boundary. You have zone 1, zone 2, zone 3. Zone 1 is their space. Zone 2, there's optimum ventilation and perfusion, while zone 3, there's some area of atelectasis, gas diffusion. So now the VQ mismatch and venous admixture further reduce the oxygen tension at a most when the alveolus cross the respiratory membrane into the arterial circulation to tighten. At capillary level is 6 to 7. At the level of the mitochondria, where it is used in cellular respiration, further reduced to 1.5 kilopascal. Now, the posture point is that point whereby aerobic respiration field. So the figure, so here you have the oxygen dissociation curve, is sigma shape. It illustrates the relationship between the partial pressure of oxygen, that is oxygen dissolved in plasma on the x-axis, to the hemoglobin saturation, oxygen attached to hemoglobin on the y-axis. There are factors that shift the oxygen dissociation curve to the right, that is, the hemoglobin has less affinity for oxygen, which includes acidosis, uh, pregnancy, anemia. There are factors that also shift this curve towards the left, that is, hemoglobin has increased affinity for oxygen, alkalosis, abnormal hemoglobin, and still blood. So these are just the anchor points here. The ICU point, as we say, is 7.9, corresponding with a saturation of 91. Now, the Boyce effect describes the movement of the curve towards the right when there is increased hydrogen ion concentration. We now move on to carbon dioxide transport. The body contains roughly about 120 liters of carbon dioxide, and every minute 200 mils of carbon dioxide is being produced. Now, the transport of carbon dioxide can be basically in three forms: either dissolved in plasma, attached to hemoglobin, or as bicarbonate. 90% is transported as bicarbonate to the lungs for excretion. And finally, these
Thank you, Dr. Jig, for the presentation. The next presenter will be Dr. Odibo Michael. Please go ahead.
Francis, you want me to share? Okay, great. It's okay.
Good evening, professors. Good evening, consultants. Good evening, senior colleagues and colleagues. My name is Dr. Odibo Michael, a senior registrar in the Department of Anesthesia, Ahmadu Bello University Teaching Hospital, Zaria. And I'll be discussing this evening overview of cardiovascular physiology. The cardiovascular system is the system primarily responsible for the pumping of blood and circulation of this blood to tissues and organs for adequate tissue perfusion. The functioning of this system is what we'll attempt to discuss in the next 30 minutes. I'll be discussing this topic with the following outline: introduction to cardiac cycle, to cardiovascular responses in anesthesia, and conclusion and references. By way of introduction, the cardiovascular system consists of the heart and two vascular systems, the systemic and pulmonary circulation. The heart pumps blood through these systems. The pulmonary circulation is a low pressure circulation that is primarily responsible for the oxygenation of this blood or for gaseous exchange. Whereas the systemic circulation, a high pressure system, delivers this blood to individual organs that allows for tissue perfusion based on metabolic demands. Blood pressure and flow are largely controlled by the autonomic nervous system. Surgery and anesthetic drug also play a role in this. The heart comprises 4 chambers, divided into the left and right side, each with an atrium and a ventricle. The atria are for reservoir of venous blood, whereas the ventricles are the major pumping chambers that help to deliver this blood into the vascular systems. The left ventricle is of utmost importance because it delivers the blood into the systemic circulation, which, as we have said before, is a high pressure system. As such, the left ventricle is not surprised to be much thicker and more muscular, with more muscular wall than the right ventricle. The heart has four chamber valves that ensures blood flows in one direction. The valves are divided into the atrioventricular valves and the outlet valves. The vascular system consists of 2 separate circulations, as I've mentioned. Blood flows through the vascular beds from the arteries, arterioles, capillaries, veins, and venules. The capacity of blood in each of these vascular beds differ with the veins and
Francis, are you sharing again?
Hello.
Francis.
Hello, sir. I think you should just go ahead and share.
Okay.
Hello, can anybody hear?
Yes, exactly. I can hear you, Dr. Mike. Go ahead.
Okay, I wanted to know if I should share the presentation.
You can share if you have access. Share your own.
Okay.
That's right.
I don't have your recorded version here.
Okay, if you don't, could you please unshare so that I can share?
Stop sharing already. Thank you.
Okay.
Pick up from where you stopped, please. Thank you. Is it the recorded one you want to continue with, or you want to present live?
Yes. Okay, can you hear me?
Yes, we can hear you.
Okay, let me just continue with this recorded one here. I can just continue. Okay. Sorry.
I think when you tap the space bar, you can be moving the slide to where you stop. Just expand the window, that window.
I'm sorry, I don't even know what I got. We can't discuss the electrical impulses of the, without talking about the ECG or the electrocardiogram. So I know that this topic, because it's large, the ECG itself will be discussed by another presenter in the coming series. So you can see from the diagram, the electrical impulses of the heart are measured by placement of electrodes in different parts of the body. You can see the electrodes connected to the limbs known as the limb leads, and the ones 1 to 4 connected, 1 to 6 connected to the chest, known as chest leads. We also have, they can also be classified as bipolar leads or unipolar leads, depending on whether it is connected, the lead is between 2 active electrodes, or and just connected as an electrode measuring from an imaginary 0 point. On the right, you can see the what a normal ECG graph or tracing looks like, with an isoelectric line running horizontally, a P wave, QRS complex, ST segment, T wave, PR interval, and QT intervals. Each of these having significance when it comes to the electrical activity of the heart. The P wave measures the atrial depolarization, which of course usually precedes atrial contraction. The QRS measures the ventricular depolarization, after which there's a pause known as the ST segment before the repolarization of the ventricles. PR interval, QT, as indicated. Pacemaker action potential. We talked about electrical impulses being generated from the conducting tissues of the heart to the muscles. These conducting tissues generate impulses, which are divided into 3 phases: phase 4, phase 0, and phase 3. They are unique in that they have a resting membrane potential, which is very much unstable. And it's unstable because of increased conductance of sodium in this phase. So it doesn't allow the resting membrane potential to stay for some time before additional impulses. In essence, at every point, impulses are being discharged, and due to the influx of sodium ion into the cell at this point in phase 0. Sodium ion impulses, sodium ion conductance increases the electrical positivity of the cell from -60 to -35, at which point, which is known as the threshold potential, the calcium channel ion begins, the calcium channels open to allow a slight depolarization, a slow depolarization, which is a bit slopy, known as the phase 0, significance of which you might likely thought of. Influx of calcium increases the potential of this sinoatrial pacemaker cell to above 0, at which point calcium channel closes and potassium channel opens, allowing for efflux of potassium. We know that potassium ion is positively charged, so efflux of potassium out of the cell will cause the cell to become negative. Electronegativity increases to its lowest value of 60, at which point the cycle starts all over again. Note that the resting membrane potential never is never stable. It's always discharging. Hence, the name automaticity being experienced by the SA node. The SA node has the highest rate of depolarization of all the pacemaker cells. Therefore, it is the primary pacemaker. But in situations where it fails, the other pacemaker will be triggered to prevent electrical stasis, even though rate of depolarization would be reduced. The cardiac myocyte action potential is a little bit different. Look at the diagram. We find out that it starts from phase 0 slope than what we saw in the pacemaker potential, because here flux of sodium ion, unlike in the pacemaker where we had slow influx of calcium ion. This rapid influx is responsible for the very steep zero. And because there's rapid, sodium channel suddenly closes, allowing for influx, opening of potassium ion, which is known as the initial or early repolarization phase. The early repolarization phase is closely followed by the phase 2, known as the play 2, characterized by the influx of calcium ion. This calcium ion influx is responsible for balancing of the initial repolarization caused by sodium efflux. This prevents the cell from tetany, and at this point, no extra or stimulus can cause stimulation of the cell at this point. After the play phase is followed by a descent. caused by closure of calcium ion and influx and continuous efflux of potassium ion, which never closed at any point from the initial repolarization phase. And because potassium is a positive charge, as it leaves the cell becomes more negative, down until it gets to its lowest electronegative state of minus 80 millivolts at 85 millivolts, at which point the cell goes into its resting membrane potential. But unlike the pacemaker potential, this is a bit more stable. That is why it is found along the horizontal axis with the aid, and this stability is made possible by the potassium ATPase pump, which prevents continuous influx of sodium into the cell. It allows these ions to move against their concentration gradient. In essence, potassium, which is more inside the cell, are moved into the cell. Sodium, which is more in the extracellular, are moved out into the extracellular space against their own concentration gradient. This helps maintain the resting membrane potential. We can't continue discussion without talking about a few concepts of flows when it comes to cardiovascular physiology. Concepts like the stroke volume, the volume of blood pumped by each ventricle with each heartbeat. It is said to be about 70 to 80 mils, relatively constant, but can increase as it is usually being determined by the preload, afterload, and contractility. There's a relationship. The preload is the volume of blood at the end of diastole, and there's a relationship between the preload and the stroke volume. As the preload increases, the stroke volume is set to increase. Why? Because as the heart is constantly or increasingly getting filled, its muscles are stretched, which leads to increased force of contraction. And that's what the Sterling's law is all about. That Sterling's law states that the force of contraction of the myocardium is directly proportional to the initial fiber length, which is determined by the amount of blood coming in essence, preload and stroke volume. Preload, afterload, contractility have factors affecting them, but of such as volume depletion, such as venous return. But what is constant, constant factor relating to all of them is the sympathetic nervous system or the autonomic system that affect virtually the three factors or the affecting stroke volume. Heart rate is number of contraction, number of heartbeats per minute, said to be increased by sympathetic nervous system hormones, and the exercise decreased by blood volume, decreased by parasympathetic nervous system and others. Cardiac output is the volume of blood pumped by each ventricle per minute. It's calculated by multiplying the stroke volume by the heart rate. Cardiac output must be said, it must be noted that the cardiac output changes depending on the metabolic demands of the body. Blood pressure of blood in the system, usually closely monitored as it helps to maintain tissue perfusion. Mean arterial blood pressure is equal to 1/3 pulse pressure plus diastolic pressure. You can also get it by multiplication of cardiac output and systemic vascular resistance. But it's very important to note that blood pressure does not really indicate tissue perfusion. Control of arterial blood pressure, even though we're still going to talk about the effects of CVS in response to baroreceptors and other factors, I found it, since in the spirit of discussing blood pressure, I just wanted to touch on this part. The control of arterial blood pressure is usually controlled by specialized pressure sensors located in the carotid sinus and aortic arc, as opposed to carotid body and aortic body, which contain chemoreceptors. These baroreceptors have connection with vasomotor center, and the rate of discharge to the vasomotor center is dependent on a particular pressure at a particular point. In essence, when the pressure is quite high, it increases the discharge of the baroreceptors to the vasomotor centers, which now inhibits the secretion, the sympathetic stimulation. As such, parasympathetic takes over as nature abhors vacuum. These effects in the heart will now include reduced blood pressure, reduced heart rates, reduced stroke volume, which will eventually bring the blood pressure, which is high, to normal. Conversely, if the people in the situation of hypotension, the baroreceptor decreases discharge to the vasomotor center, which is said to increase sympathetic stimulation, and the opposite effect take preeminence. Baroreceptor responses provide immediate blood pressure control, so that in scenarios of prolonged hypotension, stimulation of other mechanisms such as the renin-angiotensin-aldosterone system will take effect, allowing for salt and water retention, balance or correct blood pressure. Cardiac cycle. The cardiac cycle is the time taken for one complete systole and diastole. Duration is approximately 0.75 seconds. 1/3 is systole and 2/3 is diastole. Or in the case of very fast heart rate or tachycardia, this the ratio approaches 50-50 and compromises diastolic filling and coronary circulation. The cycle can be divided into 6 to 7 stages. You just take a look at this. It's talking about the different stages of the cardiac cycle. I think I might look at this one because this, in addition to the cardiac cycle, looked at all other waves which these are things that happen concurrently during the function of the cardiovascular system. Lower down here, we can see the heart sound, we can see the ECG reading. Here we can see the jugular venous wave pulsation. Here we can see the pressure volume loop or pressure volume curve. These things work hand in hand. I feel there's need to discuss them as one to make it easier. In the cardiac cycle, talking about pumping of blood, distribution of this blood or circulation of this blood to the tissue to allow tissue perfusion, adequate tissue perfusion. We said that the contraction mechanism of the heart is usually preceded by electrical impulses. And this can be shown in the ECG. As you can see, the P wave coming before A wave. P wave is atrial depolarization, which eventually leads to build-up of pressure, the contraction of the atrium, and pumping of blood into the ventricle. But as this blood is pumping to the ventricle, you can see that this A wave goes down, the pressure reduces, such that the pressure in the ventricle becomes higher than pressure in the atrium, closing up, shutting up this atrioventricular valve here. And because it is on the left side of the heart, we're looking at what the mitral valve. Closure of this valve causes the ventricular depolarization, which eventually will lead to a mechanical process called ventricular contraction. But then this valve is closed, the aortic valve is closed, pressure is rising because of contraction. It doesn't immediately lead to ejection of blood, it builds up pressure. And because it's building up pressure and no volume increase as the valves are all closed, it is called isovolumic contraction phase. And that is the beginning part of systole. As this pressure rises to above 80 or 80 and above, it causes the opening of the aortic valve, the outflow valve, causing the left ventricle to eject blood out of the system. This blood that is being ejected out of the system with time will also reduce the pressure in the left ventricle. And as the pressure reduces, what we have is a situation where, in spite of reduction in pressure, there's still a momentum that still pushes blood out until a point where the pressure in the left ventricle becomes less than the pressure in the aorta, and this causes the aortic valve to shut close. But this, what we're describing now to this point, is what happens in the ventricle. An interesting thing is also happening in the atrium. If we're going to take note, while the pressure in the ventricle is building up, it cannot overcome the aortic valve immediately. So it pushes back on the closed mitral valve. And because the mitral valve is very competent, it only adds to increase the pressure in the atrium that had already emptied. And this increase in pressure is what leads to this C wave that is seen in the jugular venous pulsation. Back to this side. While the aortic valve closes, The mitral valve, which is still closed, was, okay, let me put it this way. I say why this is ejecting. The atrium is being dragged, increasing its length, thereby reducing the pressure in it as the volume length extends due to the contraction of the ventricle. The atrium length, myocardial length, increases its volume. And as the volume of the atrium, empty atrium is increased, the pressure drops. That allows for venous return into the atrium. That's on the atrial part. So we don't just concentrate on the ventricular part. Something interesting happening on the atrial parts of the heart. Passive filling is also happening while this ventricular contraction is going on. As the ventricular contraction continues, or the pressure or pumps out more blood and there's reduction in the pressure in the ventricle, the aortic valve closes. The ventricle is forced to relax. Let's look at what is happening in the ECG. T waves corresponding to the T wave, at which point you have repolarization T wave, and this repolarization causes the heart. But this relaxation of the ventricle is, the pressure is coming down, hasn't come below the mitral valve. So the mitral valve is still closed, aortic valve is closed out. So it is known as the isovolumic relaxation phase. That is because both valves are closed and pressure is dropping, the heart is relaxing, and the volume remaining in the left ventricle is constant, hence the name isovolumetric contraction phase. So as this relaxation continues and the pressure continues to drop, and the atria is sleep, what happens is that as at a point, the pressure in the atrium rises because of that passive filling phase. Above ventricular pressure, which is dropping, and this is for the V wave that is seen in the jugular venous position, and it opens up. This opens up the mitral valve. As the mitral valve opens, there is now filling of the ventricle, passive filling, and this continues, and is responsible for. It is said to be responsible for 70 to 80% of ventricular filling phase. The remaining 20% is by the contracted atrial stimulation or atrial contraction, which happens later. But remember that in tachycardia, because of the shortening of the diastolic time, this atrial contraction is responsible for about 40% of ventricular filling. On the heart sound, heart sounds are usually due to closure. Normal heart sound are usually due to closure of valves. So you look at it here. The first heart sound is heard at the closure of the mitral, as mitral valve closes, because the valve of the left side closes slightly ahead of the right side. The valve, the mitral valve closes before the aortic valve. So first heart sound is heard here, and as the aortic valve closes later, the second heart sound is heard. This is just trying to take a look at the link. Flesh, this slides just add flesh to everything that we have just explained. We're working within 30 minutes. So I just look at it this way, and the slide probably will be made available so that if anybody wants to look at it, you compare with what we have discussed. Another concept we want to talk about is not really an entirely different concept, but pressure volume loop. The pressure volume analyzing the cardiac cycle, it shows the volume of blood move from the left ventricle, how much pressure is generated. It involves a graph of the ventricular volume on the x-axis versus the ventricular pressure on the y-axis. It is read in the anti-clockwise direction. Let's take a look at this. If it is read in the anti-clockwise direction, it means we're going this way. Okay, we've already said it's a graph of pressure versus volume. It's being read this way. So what is the implication? We start from the point that all valves are closed. All valves are closed means we have nothing is moving in and nothing is moving out of that particular chamber. That is isovolumic. The volume remains the same. And because the pressure is rising, we're looking at a heart that is building up pressure, contracting. So this invariably becomes the isovolumetric contraction phase. This pressure builds up until the intracardiac pressure exceeds the systemic peripheral pressure. This opens up the aortic valve. causing the ventricular emptying. You can see this point is a ventricular emptying. Some people will see questions where people are asked what happens in the mid-cardial phase. If you say you're still in order. This pumping leads to, after emptying, what we have here is all valves still closed, but the pressure is coming down. Of course, pressure reduces during relaxation phase. And because the volume inside is the same from the fact that all valves are closed, pressure dropping, this side is the isovolumetric relaxation phase. So some significant points until you get to the end systolic volume. Some things to note are the stroke volume we've talked about. In the pressure volume loop, the significance, the pressure volume, the stroke volume can be gotten as the width of the graph, and that is the end diastolic volume minus the end systolic volume. Remember, the end diastolic volume is the volume at the end of diastole, which we've talked about as the preload. Then the stroke work, that's another thing they can ask. Stroke work, the significance in the area of the graph is a stroke work. Remember, in physics, the pressure multiplied by volume gives us work.
That's the first few
in essence, you just find the area of this graph. Remember that there are lots of pressure volume loops in the body or even in the heart. The right-sided, right ventricular pressure volume loop is slightly different from this. We're focusing on this for obvious reasons. Factors that modify the loop include preload, contractility, and afterload. These concepts keep coming on at one point or another. Preload. What is this preload? Preload is that diastolic volume that we've talked about. What is the significance of increasing preload to the pressure volume loop? As you can see, this is the normal one. As preload is increasing, it is shifted to the right. Just in case you get to be asked, what is the significance? You shift the pressure volume loop to the right. Okay. The next slide, contractility, the intrinsic ability of the heart to do work with a given pre or afterload. It is gotten as the graph or the gradient of a point in the end systolic pressure line. You can see it touching here. So the significance of increasing is that you make the gradient to be a bit more steep slope. Instead of slanted, it's steep. So it moves it to the left, as you can see. The direction is moving to this. This is more straight than this one that is slanted. So that's the significance of increasing the contractility. So drugs that increase contractility of the heart will affect the volume pressure loop this way. The afterload, ventricular wall tension required to eject blood. What is this? It is, how do you get it? Slope of a straight line joining the left ventricular end diastolic volume to a point in the end systolic point, which is somewhere here. Increasing afterload will move it just like the preload to the left, just in case you one gets to meet kind of thing, just to understand the significance and what each of these does, the pressure volume loop and the drug that can affect each of them. Coronary circulation, okay, because of want of time, coronary circulation, okay, the supply to the heart about 200 to 250 mils. The left side of the heart is thicker, and as such, there's high chances, high pressure area, there's high chances of compression of the left coronary, and that is why it is said that the right coronary supplies the heart at all phases of cardiac cycle, but the left especially supplies the heart during diastole. It's very important to note that. Control of the cardiovascular system, 3 factors control the vascular system: the nervous control, the humoral control, and the local control. The nervous system, most important, is sympathetic and parasympathetic nervous system. So we're not going to forget about the baroreceptor reflex we talked about at the other time, and even our anesthetic drugs. We might come to them later. Humoral control. Hormones also have effects to play in cardiovascular control of the body. One, adrenal medulla releases epinephrine, norepinephrine into the circulation. We talk about the renin-angiotensin system, which is stimulated or whose activity is in the kidneys, but which are stimulated, whose constituents like the angiotensin are produced outside the kidneys, because you even see the aldosterone produced in the adrenal cortex. These are in response to different factors such as pain, trauma, hypovolemia, hypotension, hypoxia, and what have we. When this medulla releases epinephrine from into the circulation, what is expected to happen is there is affectation of both the conducting and the muscle cells that affect contraction or electrical and mechanical activity of the heart, just to restore whatever change is at the moment affecting the normal. For the renin-angiotensin system, cell is activated within the kidneys in response to, okay, let's say decreased extra.
Thank you to the presenters for the presentation. Even though we are sorry we had to rush you because we're trying as much as possible to keep to time. Question and answer session. If you have any question, please you can kindly raise your hands up. And we already had some questions asked in the questions and clarifications in the chat box concerning the Laplace law of equation and then the other non-pulmonary functions of the lungs, which have non-pulmonary or non-respiratory functions of the respiratory system, and they've been. Then other questions, you can also continue writing in the chat box, or if you have any, you can just raise your hand. Thank you very much. Questions and comments, please. We're waiting.
Hello, Chief Rukaya. Sorry, I just wanted to add something that I'm sorry about the presentation. We actually did a recording because I suspected there might be a bit of network issue around. I don't know, listening to my own presentation that was recorded, it was really skipping. I just hope it wasn't the same with every other person because my network right now is not really very good. And I would just want to apologize for that also.
Yes, we did actually have some parts that skipped, but then network problems, I think it's part of us, and we all know that. So I'll also help join you in apologizing to the other people. Sorry for that. To improve, and we'll try to sort that out. Thank you very much. Thank you, Chief.
Yes, my hand is up. Can I say something?
Yes, sir. So please go ahead.
Yes. Sorry, thank you very much for the questions. I noted that question in the chat box, which somebody said, did we skip slides? And I answered yes, and I apologize. And that was it was from me because you allotted me that time. And then since I was the one sharing the recorded presentation for the respiratory physiology, I had to keep tapping to move to the end. So I'm sorry about that. Maybe some of the questions asked around that area are on those slides. But I think you're going to have the slides at the end of it all. Thank you. I think there is a question on Laplace in the chat box. There is a question on the non-respiratory function of the respiratory system. This is directed at the first speaker, Dr. Maimie.
Yes, Asa, it was a problem. There was a writing of the equation, and he has addressed that. It's 2 instead of 4. And then he has also addressed the non-respiratory function of the respiratory
you put
system.
it in the
also.
chat box.
He replied, yes, sir.
Okay, thank you.
You're welcome, sir.
Please, questions or any clarification? Okay, someone is saying they didn't see the response on the Laplace equation, please. Maybe we should resend.
Okay, so let me just, I'll read it out for him.
Okay, and yes, thank you.
Yes, he doesn't know whether there's another variation of the Laplace. So Laplace, so the first presenter replied, it's T over R. It's 2. In the presentation, he made a mistake. I wrote 4 instead of 2, so he corrected it. It has also been reposted again. Thank you very much for that.
Thank you.
Yes, sir. We're still waiting for questions and comments, corrections, please, or additions. Sir, can I hand over back to you, sir?
Okay, if there are no questions.
Yes, I would like to hand over to the chairman, NSC Education Committee, sir. Thank you very much for the opportunity.
Thank you very much, Dr. Rukaya, for moderating this important session, being the first. All these basic sciences, but I want to remind you, especially the residents going for exam, that respiratory physiology, cardiovascular physiology is very important. But then these are just representing all the other basic sciences areas that you need to revise. So we urge you to also go and read autonomic nervous system, renal physiology, and so on, because we cannot present all these basic sciences over the course of the week. I mean the year, because there are many topics that we want to present. But we want to build on this so that it lays the ground for further discussion in the coming weeks. Just before your exam, there will be case-based discussion. So if we don't revise these areas, it is difficult to actually make any sense of the discussion on this platform, because we will be having very senior colleagues who volunteer to be panelists in the future. where we'll be discussing also principles and practice and other areas. All right, so this is what I have to say for now. And I want to apologize for any network glitch. I think it is not within our control, but like one of my mentors always say during tutorial that it is worthwhile getting a good phone, a good device, and always try to change location so that you can maximize the benefits of these webinars. So I want to thank you very much for keeping faith with us and sparing the time to join this. We want to encourage you to send in your suggestion to any of the officials of the NSA, and it will be channeled to me as the the chair of the NSA Education Committee on ways to improve. So we'll be taking that. Some of them we can take immediately, some of them will take it and plan for the future. So thank you very much. Let me call on the Secretary of the Education Committee, Dr. Oranusi, to give a vote of thanks. Thank you.
Thank you very much, Mr. Chairman. On behalf of the Education Committee of the NSA, and indeed on behalf of the Chairman of the Education Committee of the NSA, Dr. Hassan Dati Mohammed, we would all like to thank the NSA President, Dr. Busola Briggs, the moderator of today's webinar, Dr. Rukaya Sidi. We would like to thank the presenters, Dr. Maimie and Dr. Odibo. Especially, we want to thank the two presenters because they obliged to present the topics for today on a very short notice. So we would like to thank them specially. We'd also like to thank the admin officer, Mr. Francis Dinwoke, and of course, all the participants, members of NSA, our residents, our consultants, our trainers, and our residents who have participated in the webinar today. Thank you very much.
Thank you very much, Dr. Oranusi. Please, if there is any senior person here, Madam IPP Professor Nwaso, I couldn't see her if she's around, and General Gumbi or any senior person, please have to say something before I hand over to, I think the president will want to say something. Dr. Busola will want to say something, but if there's any senior person, please step out to say something and before we do that. Okay. Madam President, please. You have some announcement to make. Dr. Briggs?
Yes, please.
Please go ahead.
Good evening, everyone.
Yeah.
Can you all hear me?
Yes.
Yes, ma'am. Yes. Good evening, everyone. It's my pleasure to have you all on board this evening. This is our first webinar as a new ESCO for this year. And I must say I'm excited to have you all on behalf of the Board of Trustees and the Executive Committee. I want to say thank you for this well-attended session. We were close to 170 at a point, but 167. And we want to really thank you because without you, there would be no webinar. So I'm sure you all had an exciting time. I want to first of all start by appreciating some of you here. I want to start with the Board of Trustees themselves and also some notable elders amongst us for having supported this vision all the way. I want to acknowledge the president, former president, Professor Ogboli Nwaso, whose project this is because she started this as her pet project and we believe in it. So please, I want us all to give her some virtual appreciation. She has done well and we are carrying over and running with this vision because it's a laudable one. I want to thank the chairman of the two colleges Professors Ilori and Isamade. They have been so supportive, the faculty secretary of a National Postgraduate Medical College and also the West Africa College of Surgeons. You have all been so supportive, and so many of you. Everybody, in fact, has been so supportive to this course. We are happy and we pledge that we will serve you all. And like the chair of the education committee said, we welcome suggestions from you. Our doors are open. We want you to talk to us, how we can improve our services. And again, I want to thank Dr. Deity, my president-elect. He's been so supportive, he's so wonderful. He's handled this so well and even gone beyond our expectations. Please stay back and enjoy this education committee and the program they have for us. I'll stop for now and ask the PRO to please give you some few announcements. Thank you. Dr. Oshele, please, over to you.
Okay. Good evening, our trainers, teachers, and our esteemed NSA members. We just quickly want to intimate us about our website and our social media handles as NSA. We noticed that a number of us have not been taking advantage of this NSA website. Please, our website, the website is www.nsanigeria.ng. www.nsanigeria.ng. And we have exciting features for you on the website. For example, you can pay your NSA dues and even make donations on this website. In the coming days, I'll be sending some graphics on our social media handles to carry us along on how we can pay our dues on this website. You can also access major journals, both international and local journals, through a link via the website. Once you access the website, just go to the menu, click on it. You'll see the education listed there and where you can connect to the. We also try to illustrate to us via our social media handles how we can do this to enjoy and to get to access some of these journals. There's also a link to the World Continuing Education Alliance, that's WCEA, so that you can earn CPD points or study online and offline. You can also access some research articles and even get to see live webinars on this WCEA. There's a link on that website to WCA where you can enjoy all these things. Then our recorded webinars, both the past and even this one, can be accessed on the website too. And even some past conference videos can be accessed on the website. While on our social media handles, we have WhatsApp page, Telegram page, Instagram page, Twitter, Facebook, and YouTube. For our WhatsApp, we have 2 WhatsApp pages, and the first one is filled up. We have 518 members. The second one, we have 372. We want you to be active and engage us, just like Madam President and the President-elect has said. And then the Telegram page, we have about 316 members, and a lot of persons have not been active on that particular page. The name is Nigerian Society of Anaesthetists. Nigerian Society of Anaesthetists on Telegram page. You can join us. And then on the Instagram, we have about only 37 followers on Instagram. So we want you to follow us on NSA Nigeria on the Instagram, NSA Nigeria. We also have Twitter page. On this Twitter page, we have currently 124, we have 72 followers. And then the name is the Nigerian Society of Anaesthetists. The Nigerian Society of Anaesthetists. Please kindly follow us on Twitter. We also have a Facebook page, and currently we only have 124 followers. It's also the Nigerian Society of Anaesthetists. And then we have a YouTube where most of these videos of our past webinars and even this current one are uploaded. So please kindly subscribe to our YouTube page, Nigerian Society of Anaesthetists. Thank you.
Thank you very much, Madam President and the PRO. So this webinar has come to an end. So we hope you will keep a date with us next week, same time. A couple of the webinars, sorry, I have to say this, a couple of the webinars coincide with the election days in Nigeria. So we're going to change the date, either a Friday or a Sunday as appropriate. So see you next week, and thank you. Goodbye.